Okay. Hi, everybody. Happy New Year. And thank you very much for your patience. I will try to make this brief because we've lost a lot of time. We had some technical difficulties, but I'm very, very excited to have Dr. Palinkas presenting on qualitative and mixed methods. He is, I think, one of the leaders in mixed methodology. And without any further ado, I think, yes, one thing I would say, Dr. Palinkas, is you should let everybody know if you want them to interrupt or save the questions for the end. I'm going to kind of get off and try to send an email to other people who might be waiting in the other room to let them know that we've moved to a different Zoom room. So I won't be there for a while, but take it away, Dr. Palinkas, and thank you all for being so patient with our technical problem. Okay.
Well, I just have to say, I begin by saying I am so relieved that this is not a problem that I caused because oftentimes I find myself to be technologically challenged, which is a little ironic since I've been placed here in the School of Public Health as head of a new initiative to explore the role of artificial intelligence in the field of public health. But in any case, I'm here today to tell you a little bit about the work that I've been doing in qualitative and mixed method research in the field of implementation science, which is a field that I've been a part of, probably for the last 2 decades or so. Normally, when I give a presentation like this, I'm trying to explain to people what mixed methods are, but I'm kind of hoping that you have a little familiarity with it. But I want to begin by explaining how I came to the use of mixed method designs in the field of implementation research. For those of you who have not been involved in research on implementation of evidence-based practices, interventions, policies, and programs, it's a field that really began about 26, 27 years ago as a result of reports that came out of the Institute of Medicine that really documented the discrepancy or gap between research and practice. With the idea being that a lot of clinical care that was being delivered at the time was not necessarily evidence-based, and a lot of the evidence base was not necessarily getting into routine practice. In fact, studies had shown at the time that it took about 17 years between the time that someone had identified a priority for research funding to its use in routine practice. And there were many reasons to explain that and account for that. But the fact was that while a lot of groundbreaking research had been done in terms of development of innovative and effective approaches to delivering healthcare, that many of those approaches were not being put routinely into practice. So if you think about the traditional transition pipeline, we spent a lot of time thinking about could a program work through efficacy studies? Did it work through effectiveness studies? But the challenge was how to make it work. And that's where the field of implementation and dissemination research came into being. The field of implementation science simply is the scientific study of methods that promote systematic uptake of research findings, other evidence-based practices, and routine practices, thereby improving equity and effectiveness of the delivery of health services. Now, many times mixed methods have commonly been used in where qualitative methods are combined in an integrated fashion with quantitative methods to achieve a number of different aims in the field of implementation research. So many times it can be used to where the quantitative measures look at the intervention or implementation outcomes. The qualitative methods measure the process of implementation. Or qualitative methods, as in most clinical research, explores intervention steps, generates conceptual models along with testable hypotheses. The quantitative methods are used to confirm those hypotheses or confirm the validity of the models and theories that are generated by the qualitative methods. Quantitative methods investigate intervention content, while the qualitative methods focus on the context in which that intervention is being implemented. Many times, quantitative methods can incorporate the perspective of the researchers, but the qualitative methods are used to incorporate consumer or practitioner perspectives into the research. And then finally, oftentimes, one set of methods is used to address the limitations of the other. So my work has pretty much involved each and every one of those aims and purposes over the years. But in the process of doing so, I've been particularly interested in focusing on how useful these methods are, both in terms of how valid they are and how reliable they are. So, those of you who do work in the qualitative domain, think about the value of the work that you do in terms of how credible it is, dependable, transferable, and your use of reflexivity to evaluate the quality of the information you collect and the way you go about analyzing it. And they're in many ways comparable to the way that statisticians think about internal and external validity, reliability, and then the distinction between objectivity and subjectivity. The areas that I've been primarily involved with in enhancing the validity and reliability of qualitative methods has focused in five major domains, if you want to call it that: measurement development, community engagement, sampling, assessment of consensus, and rapid qualitative methods. And probably going to go through this very quickly given the limited time that we have available. But I'll begin with measurement development, where I've been interested in looking at how you enhance both the internal and external validity of measures to assess implementation outcomes. Over the years, I've been involved in developing a number of scales and instruments that have been used to assess both the process and the outcomes of implementation itself. One of my more recent efforts was to develop a scale used to measure both the capacity and the determinants, or the outcomes and the determinants of efforts to sustain evidence-based practices. This began with an aim that was intended to look at core components and their interrelationships across the sustainability of prevention programs and their supporting infrastructures, and then designing a measurement system for monitoring and providing feedback. This was done in collaboration with SAMHSA, their Mental Health Services Administration, and the Center for Substance Use Prevention, and then pilot test the predictability of that measurement system and the feasibility of its use to evaluate the likelihood and to improve the likelihood of successful sustainment. So we looked at four SAMHSA prevention programs. One, the State Prevention Framework Initiative, the Drug-Free Community Support Program, the Garrett Lee Smith Suicide Prevention Program, and the Implementing Evidence-Based Prevention Practices in School program. we began with essentially a qualitative approach to develop a draft scale, if you will, which asked people about their uh, degree to their experience essentially with not only implementing but sustaining evidence-based practices. So, in the first phase of our research, we conducted interviews with 45 key staff of 10 different SAMHSA-funded programs. We also interviewed 9 SAMHSA program officers. And we began that process by asking them open-ended questions about their experience with implementing and sustaining, their perception of barriers and facilitators to sustaining those programs. We had them do a free list exercise where we asked them, what do you think of when you hear the term sustainment or sustainability? What is it about your program you'd like to see sustain, and what do you think it's going to take to sustain them? And then we used one of the most commonly used frameworks for implementation research, the CIFR, Consolidated Framework for Implementation Research, and then went through a checklist of all the domain elements and asked them, how important do you think this is with respect to sustaining an evidence-based practice? We used a grounded theory approach to analyze the open-ended questions. We conducted frequency counts, thematic analysis, and a rank ordering of the top 10 nominations of the free list exercise. And then we identified the percent of informants who cited a domain as being high or very high importance and calculated a mean domain score. On the basis of that, we conducted an evaluation with a number of members of these grantees that were being funded through these 4 different prevention programs by SAMHSA. And using confirmatory factor analysis and one-way analysis of variance and Pearson correlations, identified a set of predictors and outcomes. So we basically ended up with a 35 item scale that we found to be both valid and reliable. And we found that when the funding ended, there was a significant decline in several of the determinants of sustainment, responsiveness to community needs, coalitions, partnerships, and networks, organizational staff support, leadership engagement, and feedback and outcomes. Actually, there had been an increase that is incorrect. There was an increase in those determinants with respect to their ability to predict successful sustainment. So that was one area where we've seen the use of mixed methods in combination as a way of developing and testing instruments that can assess both determinants and outcomes of implementation. Now, with respect to sampling, I won't go into much detail about this, other than to say it ended up with perhaps my most frequently cited publication. I was interested in the notion of purposive or purposeful sampling and how that fit into the process of implementation research. And so we focused on the 2 approaches to purposefully sampling participants in a mixed method study, focusing on the similarity tools or ways of focusing on the similarity or the depth of understanding that could be used to improve internal validity, and the focus on divergence, which would emphasize the breadth of understanding and thereby improve generalizability or external validity. So we found a number of strategies that could be used to emphasize similarity, like inter inclusion and exclusion criterion, a typical case approach focusing on homogeneity of participants, snowball sampling, or extreme or deviant case sampling. And then with respect to emphasizing divergence or variation, which approximated or an ability to pay more attention if incomplete to generalization. So intensity sampling, maximum variation, critical case, theory-based, confirming and disconfirming cases, stratified purposeful, and purposeful random sampling. So those approaches have now been widely used in identifying and recruiting participants for implementation. In fact, all kinds of qualitative and mixed method studies, but specifically with respect to their use for implementation research. The third area I've been interested in is how you assess consensus. So, as you know, when more than one person is involved in a qualitative study, in the analysis phase, oftentimes you see or read when you look at the articles of the research literature that coding is done separately and then discussed until consensus is reached. Unfortunately, very little effort is given to explain what they mean by consensus and how much agreement there has to be before consensus is reached. So I was interested in, and I've been along an advocate for finding a way of documenting that consensus using tools that emerge from both qualitative and quantitative research. The two most common are the percent agreement approach, where when you're coding a transcript, you take the number of same codes applied by two or more coders as the numerator, and then the total number of unique codes applied by the coders as the denominator. And that way you can provide a calculation that gives you some sense of how much they share or how much on the same page they happen to be when they apply codes to segments of a transcript. Statisticians typically employ a kappa statistic for doing something similar with quantitative data, but you may have noticed that a lot of the most popular qualitative data management software programs like NVivo, Atlas TI, and Deduce also provide that feature for calculating a kappa statistic by comparing the coding of transcripts done by two or more individuals. Um, Another area that I've been interested in has to do with community engagement. And part of the reason for that is because community engagement and community engaged research is fundamental to successful implementation. One of the tools that we've been using as a way of engaging communities to participate in research activities has been the process of concept mapping, which is a participatory method that yields a conceptual framework about how a group views a particular topic or aspect of that topic. But it's more of a structured, it's both inductive in one sense, but structured in another, to collect data, to process that information, and then produce cluster maps depicting relationships of ideas in the form of clusters. And it can be useful for engaging community members, whether in the case of implementation research, they can be patients, clients, providers, and it occurs through a very structured step of preparing, generating focal questions, obtaining data through brainstorming sessions with participants, using pile sorts as a way of organizing the ideas that emerge from these sessions, having them rated by participants in terms of their importance or usefulness to the focal question, And then using concept mapping computer software, which unfortunately is proprietary, owned by Concept Systems, which generates through multidimensional scaling visual representation or cluster maps, and then hierarchical analysis to identify both the feasibility and importance of each of those concepts. The participants then gather to collectively process and interpret the findings, potentially reduce the number of clusters, and then determine how best to use that information in implementing the concepts that emerge. We've been using this in a study that I've been doing with colleagues at USC in looking at evidence-based strategies that are designed to increase rates of HPV vaccination, particularly with highly vulnerable populations where rates tend to be lower than the average for the United States. Um, in this particular study, we used the concept mapping exercise to determine which evidence-based strategy should we be employing to implement HPV vaccination. So we conducted this study with beginning with interviews with 75 different individuals, patients, providers, system leaders, clinic directors, advocates, and from that obtained a list of 38 evidence-based strategies. We then involved 20, I think it's 23 individuals. I'm hoping you still see that. Um, can you still see the slide presentation?
Yes.
You can. Okay. All right. No, why can't I? Um, well, there we go. Okay. So uh, we then basically involved 23 individuals in.
Dr. Palinkas, would it be, should I maybe share my screen? I can see your pointer moving around.
Yeah.
Can you see it?
There. Uh, okay. Can you see it now?
Yes.
Okay. Um, so we involved 23 people in this exercise, and this is an example of the cluster map that we identified as a result of this activity. We on the basis of this, we then had our participants review the clusters, and then identify, with respect to the level of agreement, three particular strategies that we found perhaps most potentially fruitful with respect to increasing rates of HPV vaccination. One, communicating and helping providers make recommendations and communicate with parents of eligible youth, focusing on the workflow and training of nursing and staff to facilitate appointments and collection of information, and then focusing on the access to the data that emerged from uh, electronic health records. Um, the final area that I wanted to talk about was the use of rapid qualitative methods, which has become increasingly popular in the field of implementation science. So, um, I was interested in seeing how you improve the validity and reliability of qualitative data through the use of rapid qualitative methods. And this led to the development of a technique which is increasingly being used in implementation research, uh, which is called the rapid assessment, community informed uh, clinical ethnography or community ethnography or RAPIS. This was basically designed to meet the requirements for time efficient data collection with minimal participant burden on pragmatic clinical trials. It's also an iterative team-based approach so that the heart and soul of RAPIS is that it's not an activity conducted by one individual, but rather by a team of individuals. And that team involves a form of interaction between a clinician or community member who's received some ethnographic training, basically being trained to serve as a participant observer, who interacts and processes the information they collect with in the uh, clinical version with a clinically oriented social scientist, with community members who act as external analysts. So we have used this approach in essentially accomplishing a more efficient and less burdensome to the participant effort to collect information when conducting implementation research. Now, as you know, traditional ethnographic research, much like the ones that I was trained in doing as an anthropologist, is very labor intensive. It takes a long time to do well because one has to learn the language, simply becoming part of the community, be trusted. It's usually done alone, and it involves collection of a lot of information. But a RAPIS approach really is intended to provide a balance between participation and observation so that the ethnographer is both the participant as well as the observer, but the analyst is pretty much put in the role of just being an observer and views what's going on indirectly through the eyes of the ethnographer. It also provides a balance between two perspectives, the insider perspective with intimate knowledge of the setting and the activities, and the outsider perspective, where you have an individual who's capable of asking naive questions, but with some information or background as preparation. So we've used the RAPIS, actually began up in Seattle at Harborview Hospital in the trauma center to look at activities and social interactions at the time of the very first COVID surge in April of 2020. This involved observations of site visits, meetings, trainings, and other forms, and observations of the settings in which these occurred. Now, prior to the COVID, we had an ongoing study that was funded through PCORI to look at introducing evidence-based recommendations for collaborative care in trauma settings. So, as part of this, a clinically trained ethnographer would conduct site visits of trauma centers around the country to see how they were adopting American College of Surgeons guidelines for using and making referrals in instances where trauma patients also had behavioral health issues. And then conducting informal and semi-structured interviews in each of these settings. That information then was rigorously recorded systematically through field notes, through jottings. And then the recordings and transcripts of those interviews, focus groups, and meetings became part of the database that we relied upon. Um, the participant observer then conducted meetings with myself as the external analyst to review the data that was collected, provide a preliminary interpretation, and then perhaps identify recommendations for additional data collection. So the data analysis began with the preliminary analysis by the external analysts through crystallization and immersion to get the big picture of what was going on, and then conducting a rapid thematic analysis of field notes, jottings, and transcripts. The research team would then do a confirmatory analysis where we would meet to examine a preliminary analyses and data saturation, and then suggestions for additional or alternative interpretations. The consensus then was done both through interaction and discussion, and then it was evaluated in terms of the transcripts of those meetings through the percent agreement approach that I described earlier. Um, the first study in which the RAPIS approach was done was to look at the extent to which evidence-based screening and interventions for PTSD and comorbidity at 25 centers could be achieved, and the clinical effectiveness for patient outcomes while targeting the policies that guided the use of a collaborative care model. The site visits were done by the principal investigators I mentioned, who then presented the daily jottings and field notes to myself. We went through the process I described earlier, and we then used that to map on the information that was being collected to a standard framework for assessing implementation outcomes, known as the RE-AIM framework, where we evaluate the reach of the intervention that's being implemented, the effectiveness in alleviating patient symptoms, the adoption by healthcare providers, the fidelity to the implementation efforts, and then finally the ability to maintain that intervention at the conclusion of the study. We essentially using combination of quantitative data that was collected plus the qualitative data through the RAPIS approach, were able to achieve convergence. In other words, what information we were collecting resonated with the information we were collecting through the alternate means. We used mixed methods to sample the clinic sites and classify them in terms of whether they were successful at and good at implementing the collaborative care model or doing a poor or fair job of doing that. And then we looked at that comparison of centers that were defined as being poor or fair implementers versus good and excellent implementers, and found that the quality of the implementation was significantly different um, between the two different groups of centers, so that the better you were at implementing, the greater the reduction in symptoms of post-traumatic stress experienced by the patients who were being treated in those settings. We've also used the RAPIS approach in a community setting where rather than have a single analyst, we engage the community in the process of analyst and reverse the role. So the researchers were the participant observers or the ethnographers in this case, and the community members were the analysts of the data that was being collected. This was part of a study that was designed to look at the challenges of providing treatment for opioid use disorders among Medicaid enrollees in Louisiana during hurricanes. And it was intended to see how those stressors impacted the delivery or implementation of medication for opioid use disorders, and whether telehealth or other innovations in clinical service could improve that implementation process. So we had interviews conducted with a variety of individuals at different settings, including Medicaid enrollees who are patients, healthcare providers, public health administrators, clinic directors, and medication treatment advocates. And we coded the data initially by using the research team members who conducted the interviews and the site visits, and constructed uh, a set of determinants of barriers and facilitators to providing medication during times of natural disasters, and then used a community advisory board to interpret that information and to make suggestions for additional data collection, and then to achieve consensus on how we interpreted the meaning of that data. We used then the results to recommend specific forms of implementation strategies during extreme weather events. Now, the reason why we've been so focused on developing tools like this is because they have a way of engaging people with intimate knowledge of the setting for data collection and data analysis. They enhance the validity of the data and its interpretation through triangulation, through complementarity. And they empower the participants by giving them agency to contribute and invest in the success of the implementation efforts. So I'll finish off by saying, what have I learned from all of this? Probably the two major lessons that I've learned is that if you really want to improve the validity of qualitative and mixed methods research, you need to focus on insight and interaction. Now, insight requires some kind of engagement with the setting, engagement with other people, and that engagement requires some form of social interaction. So, one cannot be an observer and not interact if you expect to get valid and reliable information. And even in the process of conducting semi-structured interviews, focus groups. The key to successful validity and reliability is that social interaction. The second lesson I've learned is the key to reliability is consistency and transparency. And both of those elements are also enhanced through social interaction. So the bottom line is in order to can successfully engage with individuals, that those two forms of activity are absolutely critical to successful qualitative and mixed method research when conducting implementation science. So I'll leave it at that. And if you've got any questions, I'm happy to take them.
Thank you so much, Dr. Palinkas. You have done an amazing job of giving us a lot of information in a very telescoped time frame. Are there any questions from anybody here right now? While you're, oh, Annie, go.
I'm not sure it's a well-formed question, but I feel like I want to hear a bit more about the inter-rater reliability, that piece of it. I know that's something that I'm a qualitative researcher, and I feel like all of last year was data collection, and now suddenly I'm analyzing tons of data with multiple teams and different, all feels a bit overwhelming. And in some of the situations, I'm the one who knows most about qualitative methods. In other situations, there's other people with similar expertise, but different ideas about how to go about it, which I imagine is fairly normal.
So
But yeah,
the process that I've used in the past is that once we've developed a code book for a set of transcripts that we're coding and have more than one coder use that code book, we then take uh, a random selection of transcripts or pages within transcripts and compare the codes that were applied. Now, we assume that most of them, follow the initial code book, but as you know, code books evolve over time as you add new codes and find new information. On the basis of that, we are able to calculate a percent agreement in the application of codes. And typically, just like with kappa statistics, the greater, the higher the statistic, the greater reliability between raters, the higher the percent agreement. So if we can get anywhere from 80% or higher, then, that's a way of assessing the degree of consensus. Um, with respect to the kappa statistic, many of these software programs have function where you take a random selection of codes and you apply that selection to a number of transcripts to see by different coders to see, how basically how their application of codes, compares with the standard that you have selected. So we use those tools. I mean, um, again, the consensus is a term that reflects more the degree of social interaction, perhaps, than it does, something that's quantifiable. But they provide approximations, and particularly when you're communicating to an audience that may know very little about qualitative methods, it's a way of sort of translating the kind of approach that you take in a manner that makes sense to them.
thank you. I appreciate that. I have promised I will do that for a couple of the projects I'm working on, so I'm reassured now that I know how to do it properly and I've learned from the experts. So thank you.
Dr. Palinkas, actually, I wanted to kind of piggyback on Annie's question because I had a very traumatic experience many years ago, and I don't know what the programs, qualitative software programs, have done since, but the calculation of kappa uh, when I did it had to do more with the application or not application of codes across the area of the whole transcript. So long story short was we had phenomenally high kappas, like onwards of 95 or higher, when as we discussed the code, because we were only able to do one code at a time at that time, we both had the two of us that were comparing our agreement. Uh, we had different underlying understandings of the code, and we were applying them in very different ways. But since the kappa was calculated on the area where the code was not applied and the area code where it was applied, and it was only one code that you could sample in the transcript, the agreement of where the code was not applied was so artificially inflated that we could never get a kappa less than 95. And I turned my back on the kappa at that point. I'd love to hear your, because it was just such a traumatic experience that I said, I will never use that, statistic again in
Yeah.
qualitative work.
Well,
Um,
I think it's part of the reason why I tend to prefer the percent agreement approach. I found I've had a similar experience where some studies, the kappa tends to work better than others. I came to the conclusion a lot of it has to do with how you construct the code book and how much information and how much detail you provide in how to apply the codes. I found that my first attempt was very similar to yours. I was getting a meaningless statistic.
Awful, awful.
But the second attempt I did, involved a great deal more effort in collaborating in creating the code book and then using, codes identified that way to test how successful other people had applied the way that I had applied a code
Yes.
in
Yeah.
a particular approach. So
Yeah.
it may, in fact, be a reflection of improvements that the programs have made in how the statistics are used. I found that in Deduce, which I use a lot in the training function, if you use the kappa when you pull down the training menu, that it seems to be much more effective than when I previously had tried using it with NVivo.
Okay, and you've packed so much. I mean, Debbie has already said she's gotten off, but it was a wonderful, wonderful presentation. And we thank you so much for your patience as to the members as well. And Deanie, the savior of this session. I don't think we've ever had one as ill-fated as this session. And I'd love to invite you back next year if you're willing to chance it with us to give us another one. And hopefully we'll have our technology ducks in a row by then. But thank you so much. And Happy New Year again to everybody and for your patience with
Good.
this session.
Thank you
Uh,
so much. This was super helpful.
Deanie, in answer to your question, there are similarities, but it's really that the Delphi technique, nominal group technique, doesn't create the multidimensional scales that are used in the concept mapping approach. So, the steps involved in collecting information and brainstorming may be very similar, but it's
Mhm.
when you get to the analysis, how the data is processed and then interpreted is something that is distinctive about concept mapping.
No, and that's Deanie, I had a similar thought of when do you use NGT versus when do you use concept mapping. The other one that I was thinking about is when does one use this RAPIS, which I've never heard of before, and I will look into, versus radar or one of the other ones. And then the third place is when do you use CFIR versus REAIM? Do you have thoughts about that? And if you do, I'd love to hear more about that at another time.
Great.
About the practicalities and what has been your experience since you do have such vast experience.
Yeah.
Yeah.
Um,
And also maybe consideration during grant application writing, right? When do you highlight the different methods to use and what aims? I think
Yeah.
that would be very interesting to me to hear from your
well,
perspective.
I will make a note and we'll invite you back for next year, as say, if you are game for it
Okay.
with us.
Happy to do so. All right.
Thank
Well,
you
Thank
so
you.
much.
take
Thank
care,
you so
everyone.
much.
Bye-bye. And
Bye-bye.
thanks, Deanie.
No
Thank
problem.
And you're going to put it on the, you're taking care of all the technology?